unstable angina. Again, that's a partial occlusion, right? Partial. But with that unstable angina, we talked about that potentially they're at a higher risk of having that full occlusion, right? That when they have unstable angina, you have to be super careful because that artery is becoming even more occluded, and if that continues to occlude more and more and more, then you run that risk of having an MI, myocardial infarction. So, moving on to MIs, right? So, you've all heard the term heart attack, right? And that's the medical term for that is myocardial infarction. That's what we call that. And this is when we have an actual full occlusion of the coronary artery. Now, there's different coronary arteries, and when you get into EKG next semester, they're going to go over all that with you. But the main thing I need you to know is that coronary artery is fully occluded. There's no blood flow going through anymore. And so now we're causing that myocardium, those cells, to actually become hypoxic, ischemic, and then eventually they're going to die off, right? Now, most of the time when this happens is because we have plaque buildup. Right? We talked about plaque yesterday. We got plaque buildup in our arteries, and that plaque ruptures. And when it ruptures, that stuff is very thrombogenic. And whenever the platelets see that, they're going to start forming those clots, and they're going to fully occlude that coronary artery. The most common coronary artery that's occluded is that LAD, the left anterior descending artery. That's that main artery that comes straight down from the heart, and that's the one that mostly supplies our left ventricle. And that left ventricle we talked about yesterday, that's probably the most important ventricle we have. I mean, they're all important, but that one, its job is to push that blood to our body. So if we take out the blood flow to that left ventricle, because that LAD is occluded, then those cells start to die, and if they start to die, that left ventricle can no longer pump efficiently. And that's when we start having those problems. If a patient survives, right? If a patient, has an MI and they survive, great, good, right? They're good to go, but because we killed off some of those cardiac cells, they run the risk of having complications. And very commonly, if somebody has an MI, they're going to have complications. Now, one thing I want to point out, so, you've seen movies where somebody has a heart attack and then they die right away, right? In real life, that can definitely happen, but in real life, people can have heart attacks and not know they have heart attacks. So sometimes you'll catch that. Somebody will come in and they're having these issues, right? And they're having shortness of breath or whatever, right? They're feeling fatigued. We go, we do our workup, we get an EKG on that person, and we can see evidence. And again, when you get into EKG next block, they'll talk about that with you. But you can see evidence sometimes that there was some type of heart damage, some death of the heart on the EKG. So not everybody's going to present with, you knowing they had a heart attack. They can come into your clinic and say, hey, I'm having these new symptoms that started a couple weeks ago, and that should hopefully prompt you to work that patient up. It's going to be some type of cardiac or breathing issue most of the time, but it could be palpitation. I mean, it could be a number of things, but most of the time it's going to be cardiac or pulmonary. So remember that. So a patient can come in and they may not know they had a heart attack. But if they do have a heart attack, you worry about them damaging that myocardium, obviously, because those cells are dead. But I told you guys at the beginning of this block that the myocardium, that's the main conduction system that electrical signal. That's what that electrical signal runs through. So if we take out some myocardial cells, we can have a disruption of that electrical signal that tells our heart to beat, right? And so as a result, they can have arrhythmias and different kinds of arrhythmias. All that means is it's an abnormal heart rhythm. It's not that typical, safe state. It could be very fast. It could be kind of shaky fibrillation, or it could be kind of this abnormal pattern of their heart rhythm. Congestive heart failure. So we take out that left ventricle. We take out some of the cells, right? The left ventricle is no longer pumping efficiently. Depending on how much we take out, right? It's no longer pumping efficiently. So if it's not pumping efficiently, what's going to happen? That blood flow is going to start backing up. It's going to start backing up. It's going to go to our left atrium, then it's going to go to our pulmonary circulation. And as that pressure starts to build up, because that left ventricle can't pump out blood like it's supposed to, you're going to start getting that congestive heart failure. You're going to start having that pulmonary edema. You're going to feel short of breath. You get a chest x-ray, and you're going to see these kind of white spots, right? Because that fluid is leaking out to the alveoli. Cardiogenic shock. So this is typically when a lot of that ventricle is taken out. So that heart can really no longer beat. It's really struggling to beat. And so if we're not pushing out blood, we get that backflow. We're not perfusion our tissues. And so we talked about that last block about the electrolytic shock that can happen. Sometimes when we take out cells of the myocardium, obviously they're dead, right? But those cells are now, that dead point is now a weak spot. It's a weak spot. We don't have that normal strength anymore because those cells are dead. And sometimes when those cells die, it can actually cause an aneurysm of pushing out of the heart, right? So so that blood is coming in, it's pushing out now that dead myocardium. That myocardium is still intact. But what you worry about is because that's a weak spot now, every time that heart beats and it pushes out into that weak spot, you worry about that heart actually rupturing. So you get a hole in the heart essentially, not talking about the septum, actual hole in the myocardium that pushes all the way throughout. And most of the time when that happens, the patient's gonna die. Like there's not a quick fix for that because there's a hole in their heart now and then it's bleeding out into their body cavities. And then you also worry about those emboli I talked about. So if you have an abnormal heart rhythm, right, if the heart's not beating like it's supposed to, you start getting blood stasis. Sometimes you can get that clot formation, and if that clot breaks off, it can go off to our brain, really anywhere on the arterial side of the house. So how are these patients going to present? So obviously we know about chest pain, right? Patients are going to have chest pain. Chest pain is one of those things that it presents all kinds of ways. Some people can have like a sharp chest pain. Most of the time they describe it as like a pressure type sensation, like somebody sitting on their chest. But they're going to have some type of chest discomfort. They may have radiation to their jaw or to their left arm. The reason behind that is because the nerves that innervate the heart, right? They all come back out to our thoracic spine. Where those nerves, where that nerve root is, where those nerves actually come out to, you also have the nerves that innervate our jaw and our left arm. So if those nerves that are irritated because the heart is damaged, sends that signal back to the thoracic spine where those nerve roots are. And you also have those nerve roots that innervate our jaw and our arm. If you cause irritation back there, you can cause irritation to those nerves as well. So that's why people get, even though the problem is in the heart, they get this what's called referred pain. So they don't have any issue with their arm or their jaw, but because where those nerves are located, they're so close together that when they're irritated, they can irritate the low nerves, and they can get that referred pain. So the patient may present with left jaw pain, left arm pain. That's classic. So yeah, that's classic. I'll just say that. They may have shortness of breath as well. So if the heart's not pumping right, start getting that back up, they're going to feel short of breath, and then they obviously may have some confusion because their heart's not pumping. Now EKGs is how we normally find this out, right? That's one of the first steps we got to do with EKG. And again, we won't get into the specifics of that because you're going to have a full block on that, and there's a lot that goes in with that. But their EKG is not going to be normal, I'll say that. There are markers, there are blood tests we can do to determine if somebody's having a heart attack, to see if there's any type of cell damage. The most specific, the most common one, the one that you're going to get when you're in clinic is called troponin. Troponin is a protein found in cardiac cells. And if the cell is dying, if that cardiac cell is dying, that cell is going to release that protein, and we can pick that up in the blood. There's different types of troponins. There's I and there's T. Don't worry about that for now. Lab will talk about the different kinds. Most of the time, you can do either or. Most MTS have troponin T. They don't really have troponin I, but either one is fine. It just really depends on where you work. But that stuff, it's released within about 3 to 6 hours of that damage, and it's going to stay elevated for quite a long time. These other ones, the CK-MB, myoglobin, AST, and LDH, these are other factors, other proteins, if you will, or enzymes too, the AST, that can sometimes escape the cardiac cell and be elevated as well, but they're non-specific, meaning there are other cells in our body that have these enzymes and proteins, and so we don't really rely on those as a test to look for an MI because you don't really know if it's coming from the heart, if one of those are elevated, because CK-MB, right, that's really specific actually for the heart, but CK-MB is also found in skeletal muscle. And so if you have an elevation of that, you don't really know, is it from the heart? Most likely it is, especially if they're coming in for chest pain, but you can't be for certain. That troponin, if that one's elevated, you can be for certain that guy, there's some type of heart damage going on there. So just an FYI slide here. So this kind of just goes over the EKG findings that you may have. Again, don't really worry about that for this block. But the table over here on the right just shows you the different enzymes and how fast they rise, how long when their peak's actually going to be seen, and then when they're returning to normal. But again, troponin is that main guy you care about. All right, so kind of moving on to our vasculature, what things we can see there. So aneurysms. So aneurysms, there's different kinds of aneurysms, but we're just talking about the blood vessels, really the arteries. All an aneurysm is just a dilation of the artery. It's just dilated, right? It's no longer nice and straight. It's bulging out on the sides. And there's different, most of the time that's because there's a type of weakness in the artery. And I talked about in the beginning of this lecture that if we have plaque buildup, that can cause that artery to weaken, right? Because it shouldn't be there. We're kind of breaking that thing down in a sense. Or if you have high blood pressure, that's going to also cause stress on the artery and cause that to weaken. Those are the most common reasons why people can develop these aneurysms. And if you have them both, right, not good. But there's two different kinds of aneurysms. We have a true aneurysm, right? A true aneurysm, and all that means is that all the layers of the artery are bulging out. So you got the intima, the media, the adventitia. The whole artery is bulging out. It's still intact though. There's no hole in it. It's still intact, but they're just bulging out. Versus a pseudoaneurysm, what that means is that you have some type of hole all between all the layers of the artery. But what's happening here is that if you have that hole going between, so you have an opening now, right? Outside of the vasculature, you have connective tissue. You have different types of tissue. You can have fat tissue, you can have skin there, you can have fascia. And that fascia, that skin, that fat can actually cause it to kind of encapsulate that hole where it causes this, it's an aneurysm, it's bulging out, but it's covered. It's covered, right? So this person, even though they have a hole, they're not bleeding out because you have some type of other tissue that's covering it. The problem with this guy is that you have that hole, and if you don't fix that, then you have a very, very high risk of that covering breaking off, not supporting that bleed as it starts to increase, and then this patient bleeds out. Now, most of the time, these pseudoaneurysms, they're going to occur for some type of procedure. They don't typically just occur like that. You're doing some type of intravascular, maybe a catheter or whatever, and that surgeon actually accidentally punctures a hole. That's how these guys form. The true aneurysms, those are going to be caused by high blood pressure and high cholesterol. Pseudo, typically from a procedure. Now, for the true aneurysms, right, these guys are hard to diagnose. And when I say that because we don't know, unless you're actively looking for this, you don't know that this patient's developing these, because they're not going to present with symptoms. So there are some things that we actually screen for. Cardiology will talk about that with you. But the main thing I want you to be aware of is that you may not pick this up. You may not know a person has this unless that thing actually ruptures. The abdominal aorta, that's the classic one that we worry about. That in physical exam, I don't remember if you guys have done this yet, but part of the abdominal exam is actually palpating the abdominal aorta. And that's what you're trying to feel for. You're trying to see, like, is this guy big or not? And if it is, if you can feel it pulsatile, we'll talk about that more in a second. Then that means you can work it up because you worry about that risk of rupture if that thing is dilated. So not only can it rupture, there's also another term here called dissection. Dissection, all that means is that the inner lining of the artery there's a defect in there, there's a tearing, if you will. And so you have that intima layer, the inner lining is torn, and what that causes is that kind of a false opening, a false lumen, a new opening. Now the blood that's coming through can actually go into that opening, into the intima. Again, the artery is still intact, it's just that inner lining that's torn. It can cause that intima is torn. Now it's blood kind of come through that, right? And as blood is coming into that space between the intima and the media, now you're it's kind of like peeling in a sense. It's kind of peeling off that artery inner layer. And when that happens, you let all this blood flow come through, it can actually partially occlude the lumen, the true lumen, right? Because think about it, right? You got this artery, now you got this tear, and it's coming down. Now you're occluding that space, because there's so much blood coming into that inner layer. And when that happens, you worry about that artery actually fully rupturing, because now you have a very weak spot, you got all this blood coming through, and that can cause an actual rupture. Now, in an aortic dissection, this is classic. This is classic for PANCE and in real life too. Typically, it's going to occur in that aortic arch. So where that blood's coming through, the left ventricle's pumping into the aorta, that arch, that's the most common place that these things are going to occur because you have so much pressure coming through that. When that happens, a patient's going to report to you that they feel like this tearing chest pain. And it makes sense because that's kind of what's happening inside. Most of the time, they're going to describe it in the chest region. Sometimes they'll say it radiates between their scapula, between their back. So if a patient ever comes to you and they say, I'm having pain, and you ask them what it feels like, and they say it's tearing, that should be the first kind of thought that comes to you, especially if they say it's in their chest or it's between their scapula. Because that aorta, it sits back there posteriorly. So yes, you're going to feel it in the pain here in the chest, but because of the location of the aorta, if that thing is tearing, they'll also report this between their scapula. If you get a chest x-ray, you may see a widened mediastinum, and I'll show you a picture of that here in a second. And then, like I said, this guy has a higher risk of actually rupturing all the way through. So here's the aortic dissection, so you kind of see what I was talking about, hopefully. So you got this tear here, right? Tear, now blood is coming through here. Now it's going all the way through, and so kind of over on this side, I don't know if you can see that guy. Over on this side, you got the tear, and then it's kind of working its way through. But look at this. Look down here as we kind of go down here a little bit lower on the aorta. You got the tear, it's kind of snaking its way through. Now it's creating this space here, and it's making this true lumen, the actual opening of the aorta, it's making that more narrow. And so if this thing fully occludes, well, now we have a big problem. That's one of the things we care about, but the most common thing we care about is this thing actually rupturing all the way through. I thought I had a picture. Oh, here it is, yeah. So here's that mediastinum. So shouldn't be this much space here, right? Typically you have your aorta, you can see the heart here, but then look how this guy's kind of branching out there. It's wide. So why did mediastinum, tearing chest pain, think dissection? Yep.
Does that blood get all stagnant and coagulate and stuff like that since it doesn't have a dissection?
It definitely can. But most of the time before that happens, especially if the patient presents, we're gonna take it to the OR right away. But yeah, if it's there and it's not moving, it definitely causes clotting, right? Yeah.
But the dissection doesn't actually mean that it's ripped open, right? Like blood's not entering the cavity.
Exactly.
It's still in there.
It's still in the cavity, but it's between the intima, the inner part of the artery, and the median, the muscle part of the artery.
So a full rupture would be something completely different.
Right. Yeah. You worry about it rupturing because now that spot is weak. Yeah. The pseudoaneurysm is from some type of procedure, right? Something poked through there, and now we have connective tissue, skin, fat, covering that bleed out. The aneurysm, the blood is still inside of the artery, it's just that inner lining is torn. So all the layers aren't all the way torn. It's just the inner lining. Make sense? If you look at this picture at the very top, I think that kind of helps visualize it as well. Cool. All right. So kind of moving on with the aneurysms. So we can really get aneurysms anywhere, right? Anywhere that we have our arteries. But the brain and the abdominal aorta are kind of the two most common regions that if they rupture, right, that aneurysm ruptures, then we have bad problems. So with the cerebral aneurysms, there's something called scapular, sometimes called berry aneurysms, because they kind of look like little berries, if you will. And they typically occur at that circle of Willis. That's that circular kind of blood vessel at the base of our brain. And most of the time, these are due to hypertension. So high blood pressure is going to weaken that artery, and over time, that artery can start to have an aneurysm. And the reason why we care about this is because we won't know a patient has this, right? We're not going to know a patient has this until it ruptures. You may find it if you're doing some type of brain imaging for something unrelated. They don't just look at the reason why you referred them for the MRI of the brain. They're going to look at the whole structure. But typically, if they're not having any issues, which most of the time they don't have it until it actually ruptures. You're not going to find this until it actually ruptures. And But when it ruptures, because of where that artery is, it's below that arachnoid space, you get the subarachnoid hemorrhage. Now between that space, and the patient's gonna present with, they were sitting there, they were just kind of hanging out, and then boom, they had this sudden, severe, worst headache of their life type pain. So it's not one of these, dad had a headache and then it kind of started, and then a few hours later it got worse. No, they're sitting there chilling, reading whatever, and all of a sudden they get this sudden, severe head pain. They call it a thunderclap headache because now you have this ruptured aneurysm that's bleeding into the brain. And in that space between the subarachnoid and that PM artery, that space, right? When the blood starts to pour into there, it's going to start to irritate the nerves that are there. It's going to irritate. It's going to cause a lot of pressure because it has nowhere to go. And so these people are going to have a pretty severe headache. If this happens, if a patient comes to you and they have the worst headache of their life, like pain, and they're in distress, and you find this, you need to get them to a neurosurgeon. There's no delay in that. You need to get them to a neurosurgeon because if not, this patient's going to die. Abdominal aorta, this is probably the most common thing you're actually going to run into in real life clinic. It says atherosclerotic aneurysm, for sure, yeah, that can definitely be a factor here. High blood pressure can as well, smoking as well. But anything that weakens that aorta, right? Anything that weakens it can cause an aneurysm. Now, there are different sizes to these aneurysms, right? Typically, it's going to be between 2 and 3 centimeters. That's normal. When it starts to increase to 5 centimeters or more, that's when that risk of rupture develops. That's when we are like, shoot, we need to do something here because if not, potentially that aorta is going to rupture, and then if that thing ruptures in the abdomen, you got so much blood flowing in there, they're going to probably bleed out and die. When you're doing your physical exam, part of the exam should be, you listen, you look, you listen, and then you feel. And you're not only pressing to kind of look for, tenderness and deep palpation, all that kind of stuff. This is one of those things, especially in your older folks, especially if they have risk factors for developing atherosclerosis. You got to make sure you're checking this, because if you don't and you miss it, well, now potentially that thing ruptures later on, and then we could have caught that before that actually happened. When you're actually doing that exam, though, and you think there's a high risk for it, you got to be super careful. If that thing is already bulging out, and you go and you push down real hard, now you just create that pressure that was needed to actually make that thing burst. So be super careful whenever you're checking that. Kind of start, laterally, work your way in real slowly until you find it. And then when you do find it, make sure you're not pressing down too hard. You got to give a little bit. You got to make it a little firm, but just don't smash on this guy's abdomen, because that might be the thing that trips you. If you find the abdominal aorta aneurysm, get them to a vascular surgeon. If it's ruptured, obviously, you need to go right away. These are one of those things that you found it, you just tell the patient, hey, watch out for these symptoms. You refer them over to a vascular surgeon. Maybe you want to call the vascular surgeon to see if they can get in a little bit earlier. But it's not one of those immediate things I got to do right now, unless it ruptures. All right, so varicose veins. So now we're kind of switching gears. We talked about the artery, now we're talking about the venous system. Make sure you write this down too, because it's not in here. So varicose veins are also known as varicosities, right? Maybe you've heard that term before. So varicosities also means varicose veins. So with varicose veins, so the veins are different than the arteries, right? The veins have these valves. They have these inner valves, and their job is to let the blood flow out and then close. That way blood doesn't fall back through the venous system. Our arteries don't have that. Our veins also are a lot thinner. They don't have that same amount of smooth muscle that the arteries do, right? So the problem with that is that because they're thinner, because they don't have that strength like the arteries do, sometimes our veins can dilate. They can dilate for a number of reasons, but when they dilate, when we have this kind of weakening of the vein, it can dilate so much that those valves become incompetent. They can't close fully. There's so much room that because that vein has dilated so much that it closes, but there's still this opening here, right? So as a result, that's going to make the blood more stagnant. It's going to cause that vein to become more dilated. So it's one of those things that you develop, and then eventually it gets worse and worse and worse unless you start to treat it. These veins typically occur in our superficial veins. They don't occur in our deep veins. So when I say superficial veins, these are the veins that are outside, like in our lower legs, but outside the muscle area. Our deep veins, they're surrounded by muscle. They're the ones that get the DVTs, right? They're the ones that are, that need that muscle contraction to help push blood out. The superficial veins are superficial. They're outside of that system. The problem with the superficial veins, though, if you have varicosities, if you have varicose veins, that blood is no longer pushing out like it should. I mean, the blood is still pushing out, but it's not pushing out normally, and so it becomes stagnant, right? When you have venous stasis, what happens? When you have venous stasis, you get clots, right? These clots, they're not good, but they're not terrible. If somebody comes to me and they have a superficial vein clot, I'm not that concerned. If they have a DVT, if they have a deep vein clot, I'm definitely concerned. Because the way these superficial veins actually drain into that deep system, there's a low likelihood that that superficial vein clot is actually going to then go into the deep venous system and then go into our lung. Could it happen? For sure it could happen. It depends on where it's at. If it's really close to that junction, and I'll show you a picture here in a second, if that superficial clot is close to the junction where it's about to enter that deep venous system, then yeah, that's a little bit more concerning. But most of the time they don't occur there, they occur far away from there. So if you get a clot that forms there, again, not good, but not too scary. Yep.
Sir, with that, so a patient comes to you, and they're superficial varicose veins. Patient says, I hate these ugly veins. Like, what would you do for them since you're not that concerned? But they don't like
Varicose veins?
Yeah, what would you do for them?
So there's a few ways to treat it. Compression stockings are the #1 way. So I don't know if you've ever seen them or they're really tight. That's what their job is for, right? And so patients hate to wear this, but when they wear compression stockings, that actually helps push that blood flow through whenever it's pushing through those superficial veins, and that can help reduce that from getting worse. Is it going to fix it? No. So patients hate that, so they don't like to wear them, and I don't blame them because we used to have because they're really tight. Like when you get to clinic, your clinic should have some of those stockings. And if you look at it and try it on, right, you're going to see that things are comfortable. Exercise is also very important. So we try to keep that blood moving. So exercise we try to get them to do. In our older patients or our overweight patients, it's harder to get them to kind of sell on. We try to get them to elevate their extremities whenever they're at rest. So we don't want them standing for a long time. I'll talk about here in a second. So if they're sitting at their desk, try to prop their feet up. That way that gravity's not pulling in. If it's really, really bad, you can send them to a vascular surgeon and they can actually strip those things, remove them, right? The problem with that is that TRICARE doesn't typically pay for that. I guess they consider it a cosmetic issue. I don't know, it's weird. TRICARE is weird.
Could you swing it though, like the patients, I hate these veins are ugly, I hate them, and like it's a mental health thing. Like, could you swing it to get it approved?
You can try. You can try. You can try anything. It's the powers that be that make that decision, right? But yeah, we try to treat conservatively because people don't want to have surgery most of the time. But definitely, it can be one of those things. I've had a lot of people say, I hate the way they look, and I've tried it. All right. So anyways, you tell me to shut up. Okay. So pregnancy, the causes. So think about that. You have a pregnant, you got a uterus, has a baby in there. There's a lot of pressure in there. It's going to compress those pelvic. You got pelvic venous return, and they can cause downstream effects. People who stand for a long time, so waiters, waitresses, people who work on the flight line, Air Force fleet. I'm sure Army has some. I think you guys stand for a long time too. I don't know what you guys do. You guys do all kinds of different things I'm not familiar with. Anything that calls for long standing, family history, definitely if somebody has a family history of this, there can be a link with that, so you ask that as part of your questioning. Anybody in your family have varicose veins? Because there's a genetic component to this as well. We talked about how the blood clots can form, so thrombophlebitis is what we call that. Again, low risk of it actually going into our deep venous system and causing a PE. Stasis dermatitis. So with this guy, this is kind of that those varicosities that have been prolonged. It's not something that happens quickly. It takes a long time for this to happen. But if you have that increased venous pressure because that blood is no longer flowing appropriately, can actually push out some of those, all that pressure can actually push out some of those RBCs. And those RBCs that are in our venous system can actually go into our dermis. And when they start to break down, they deposit this thing called hemosiderin, it's essentially just iron, and it causes this kind of brown discoloration of our dermis. And I'll show you a picture of that here. Stapes ulcers, so if the blood is not flowing appropriately, so think, we got our arterial system, we got our capillaries, we got then our venous system, and it requires movement, right? If things aren't moving, things start backing up. And so if we start having this venous congestion, it's gonna start backing up into our capillaries, and so this arterial blood flow is not gonna be coming through appropriately. It's still coming through, it doesn't come through normally. So when there's some type of delay in that, oxygenated blood coming through, you can actually, those tissues, those skin cells, the dermis, can actually start to become damaged and start to die off, and you can get these ulcers that develop. So here's an example of the kind of what this looks like, the vein itself. You can see over here, this is normal here, and as they start to dilate, those valves, they become incompetent, they don't close correctly, and so now you kind of get this worsening of that. This is that picture of that stasis dermatitis. So this is just red blood cells that are escaping to the dermis, breaking down and depositing iron, so you get this dark appearance. And this guy here, look, you got stasis dermatitis over here, and then you got this ulcerated area that's starting to break down because we have such a decrease in the amount of arterial blood coming through there. And then over here, on this other picture here with the veins, you can see the superficial veins, they're outside, they're not deep. But I was talking about, now, this is not testable, I guess we're getting at, but in real life, if you have a clot that develops in the superficial region, but it's close to that junction where it starts to go into that deep region, that's when we're concerned. There's certain parameters and there's certain measurements, of where it needs to be before we get concerned. Don't worry about that now, but we sometimes care where it's at, but most of the time, if it's far away from that junction, we don't really care. We just treat it. Typically, we'll do compression, we'll do the NSAIDs, we'll do heat, and typically your body will eventually break down that clot. Yep.
How do we determine clinically whether it's a cosmetic issue, and then how upsetting is are dangerous?
Where it's at, right? So in real life, you're gonna get an ultrasound. You're gonna get an ultrasound, and you're gonna see where it's at. And the radiology report will tell you, like, hey, this is 4 centimeters from the junction of whatever vein. Sometimes they'll even say consider referral to a vascular surgeon or consider starting anticoagulant. But the radiology report and the location is going to tell you that. Cosmetically, they're going to come in, they don't always develop these clots, right? They're at risk for developing a clot, but patients can have varicose veins and have no clot. So when you're asking your patient, what's going on, they come in, they're like, oh, I got these nasty veins. You push on it, is it painful? Sometimes it's painful, sometimes it's not. Look, is there any type of erythema and redness? Because if there's inflammation from thrombophlebitis, typically the area is going to be a little bit red. If there's not, then you may still want to get an ultrasound because maybe you're not sure. You get an ultrasound and everything's still good, there's no clot. Then you know that that's more of a cosmetic issue. But you got to question the patient. You got to do this. Makes sense? All right. So giant cell arteritis. So giant cell arteritis is also called temporal arteritis. This is classically going to be seen in your old folks. I don't even think it can happen in young individuals. I've never read any text that's said that. I've never seen it in clinic where it happened in a younger person. Think about your older folks. Rare before 50, typically between 70 and 80. As you get older, that risk increases. Young folks don't get this. They don't get this. It's going to be your older individuals, okay? So this is actually one of those type 4 hypersensitivity reactions. We didn't talk about this last block. This is kind of one of those weird ones. I talked about, you remember, type 2 and type 3 are autoimmune, right? This one's actually an autoimmune one as well. I didn't bring it up back there because I didn't want to add to the confusion. This is one of those weird, and I'll tell you this, medicine, and I think you guys know this, medicine is not black and white. We try to make it black and white here, just to make it easy to kind of understand, but when you get out there, you're going to see everything you learn here, it helps, But there's so much out there that doesn't make sense sometimes. But anyways, what happens here is that our body, for some reason, starts to see the temporal artery as foreign, essentially. So those T helper cells are going to say, hey, shouldn't be here. Come here, macrophages, come here and do your thing, start to damage, try to destroy this thing, right? Those macrophages are going to come in, they're going to invade that temporal artery, and they're going to come together, right? When they come together, what's the word I'm looking for? When they come together, I guess, was that congregate? Actually, like combine. Yeah, fuse. Yeah, when they fuse, that's all I use. When they fuse, they develop these things called giant cells. So that's why this thing is called giant cell arteritis, because if you take a biopsy of the temporal artery, you're going to see these giant cells. And all that is just these macrophages that fuse together. Now the problem with this is that when we start to damage that temporal artery, it can cause some issues, and the thing we really care about is it causing issues with our ophthalmic artery. If it starts to decrease the blood flow to our ophthalmic artery, they potentially can go blind, right? But what's going to happen is that the artery can become inflamed. When it becomes inflamed and those giant cells start to invade, it's going to cause that lumen to narrow. And when that lumen narrows, now we're not letting a lot of blood flow through to it. And when that happens, we run the risk of having ischemia. So your patient's going to come in, they're going to say, hey, I'm having pain in my, in my head or my forehead. You may see kind of this bounding temporal artery because that thing's inflamed and swollen. When you push on it, it's going to be painful. Typically, it's going to be painful. If it's affecting the ophthalmic artery, then again, you're not letting a lot of blood flow through because that thing is narrow. And so they can go blind potentially. And again, that's the thing we care about here. If it's affecting other parts of that external carotid artery, then when they're chewing sometimes, because it doesn't just affect the temporal artery, it affects kind of that whole thing. This is the most classic region where they're going to present. When they're chewing, they're going to get claudication because they're increasing that oxygen demand when they're chewing in their muscles. And as they chew, they're going to start to feel this pain, so that's another potential sign this is happening. How we're going to diagnose this? So obviously physical exam, when the patient reports their symptoms. But somebody asked me about ESR yesterday. So ESR is a lab test that lab will talk about, but it's just a non-specific lab test you get when you're looking for inflammation. You get an ESR and it's elevated, you're not going to know why unless you suspect this person has giant cell arteritis, because it doesn't tell you, like, ESR, it's not specific for giant cell arteritis. Any inflammation going on in the body, that thing's going to be elevated. There's another inflammatory lab called the CRP. Again, that's very similar to ESR. Why do we have two? I don't know, but that's another test you can get to kind of see if there's inflammation in the body. But if the ESR is elevated and they present with symptoms that are suggestive of temporal arteritis or giant cell arteritis, take that. The way we're going to actually, so the way you actually diagnose this is you get a temporal artery biopsy, you take a piece of that artery. Most of the time, we're not going to wait on that though. We're going to have the symptoms, we're going to have the elevated lab test, we're going to jump to treat that right now. Because if we wait to get a temporal artery biopsy, that's going to take too long. We're going to treat it, presume that's what it is, and then eventually get them over to a vascular surgeon. And maybe they'll do a biopsy, maybe they won't, it depends. But the way we treat this, well, we got to calm down the inflammation, right? So we're going to give them steroids. We're going to give them prednisone. They're going to take that. We're going to follow them. We're going to get them to specialists potentially. So we're going to start them on prednisone just to kind of get things under control and calm down that inflammation. All right, Raynaud's phenomenon. So Raynaud's phenomenon is one of those kind of weird ones. Essentially what this is that you get this kind of very powerful sympathetic nervous system response that causes vasoconstriction, typically between our fingers and our toes. That's the classic area this develops in. Now, different things can cause this. So cold can cause this. If you're stressed or you're having anxiety, that can cause this. Anything that increases that sympathetic tone can cause that vasoconstriction. When that happens, again, typically fingers and toes, when that happens, you get the vasospasm, right? You get the vasospasm in the fingers. Now we're increasing the blood flow to our capillaries, and so the fingers are going to turn white. And it's not all the fingers. I know this picture down here shows kind of all the fingers, but if you look at the very top right-hand corner, that's how it normally is. Like it's not all the fingers, typically a couple of them or a few of the toes. But you get this kind of vasospasm, right? So now you're not letting blood flow through the capillaries. You still have blood in the capillaries though. You're not like completely making it the same, devoid of blood. You still have some blood in there, but you have such a reduced amount that it turns white. That blood that's still in the capillaries, it's just sitting there now. You don't have that kind of push of the capillaries, of the blood flow through the capillaries to push that venous blood out. So what happens is that our tissues start to keep pulling the oxygen from that blood, and it becomes deoxygenated. So now you get this blue color. So you get the white, then you get the blue, and then eventually that vasospasm is going to relax, and then you get the sudden influx of blood coming back into that once constricted blood vessel. Now it turns red. So white, blue, then red, right? Different things can cause this. Again, cold, emotional stress definitely can cause this. If you have other factors though, that can contribute to this. Smoking. Smoking is one of the most common things we associate Raynaud's with. So, right, I told you guys yesterday that with, what was it? Transmetal angina, right? That smoking can also cause vasospasm. Smoking can also cause vasospasm here. So we talked about two things, Raynaud's and Prince-Metal, right? Sometimes autoimmune disease can cause this. And that's one of the things you do whenever a patient presents with this. There can be primary causes, meaning that there can be a primary reason, meaning that there's no cause for this. Maybe there's some risk factors involved. Or there can be secondary causes like autoimmune diseases. And typically when you're working this up, you want to make sure, you're going to try to rule out those secondary causes based off of this root. Other things can cause this as well, but again, smoking, autoimmune, those are things that I would definitely care about. So how do we prevent this? We try to prevent the things that cause this, right? If it happens, typically a patient's going to come in and they're going to say, hey, every time I go out in the cold, I get this weird kind of appearance to my hand. And hopefully they'll take a picture and actually show you this whenever they come see you. When they come see you, they're kind of normal. And they give you those kind of characteristics, and we want to try to, if they're out in the cold, make sure you're wearing gloves. Wear those little heaters that you can wear in gloves. You just try to prevent that, whatever's triggering these episodes. If they're smoking, try to get them to stop smoking. It's going to be harder to do. It's very hard to get people to stop smoking, but you encourage that, and hopefully they'll buy into that. You can treat these with medications as well. Typically, we'll give calcium channel blockers. Have you guys gotten into hypertension meds yet? No. So calcium channel blockers are a type of blood pressure medication, but what they do is they cause vasodilation, and so that's kind of one of the mainstays. If it's really bothering somebody, then we'll give them a calcium channel blocker. Most of the time, in real life, they're going to say, okay, I know what it is now. They don't want to take a medication, so they'll just live with it and try to avoid the things that hurt. All right, so hypertension. So you're definitely going to see hypertension in clinic. That's for sure. There's different guidelines out there when we talk about hypertension. When I was coming through here, we used JNC8, and that was 140/90. Now, I think in 2017, they changed the guidelines, so now we use the ACC/AHA, American Heart Association guidelines. They dropped that down to anything greater than 130/80 is considered hypertension. So 130/80. Typically, you have to have more than one reading to make the diagnosis, but going through here, they're teaching you guys 130/80. When you get in clinic, you're going to see people use all these kind of different values. This is the one that we should be using, and I think is going to take precedence over all the other ones. But this is 130/80. So what can happen with hypertension? Well, a lot of things, right? If it can contribute to atherosclerosis, because we talked about how those endothelial cells can become damaged from the high blood pressure, so it can make that worse. Definitely, it's even heart disease, because again, that blood pressure is not going only to our arteries, it's going to a coronary artery, which cause that to worsen, strokes. The blood vessels in our eyes and our kidneys, those things are very tiny. Those things are very, very small. When we increase that blood pressure, it doesn't just go to our big arteries, it goes to our small arteries too. And it can damage those. It can cause blindness, it can cause renal damage, kidney damage. So it causes a lot of issues. Now what kind of determines our blood pressure? There's three things. The volume of our blood, right? So if we're holding on to more water, if we have kidney problems and we're holding on to more sodium, we're going to hold on to more fluid, that's going to increase our blood pressure if we have more volume. Or if we lose fluids, right? If we're dehydrated, if we're vomiting, if we're bleeding out, it's going to drop our blood pressure. Cardiac output, if you're exercising, you're pushing more blood flow through because you're pushing that, you're making that heart work. As that blood pressure, as that blood is coming through the aorta, it's gonna increase that pressure because you're pushing a lot more through. If you have heart failure, we kind of talked about that last block, you're not pushing enough blood flow through, so we're gonna start to drop that blood pressure. Thankfully, the kidneys are gonna come and try to save us, but they're gonna make things worse. Vascular resistance, so if we have constriction of our vasculature, right, if we take a medication and it causes constriction, then it's gonna make that lumen more narrow, which is gonna increase that pressure. Or if we have vasodilation, we have shock, right? If we have shock, like we talked about last block, if we make that lumen a lot bigger, we're gonna decrease that pressure. So the reason I point that out is because when we treat blood pressure, we give them medications that affect either one or all of these. So with the volume, we can give diuretics that can actually have them not hold on to sodium as much, so they pee more. Or Lasix is another one, typically that's reserved for heart failure though. Beta blockers, they kind of slow down the heart rate, so we decrease that cardiac output. And then the vascular resistance, I talked about the calcium channel blockers, they cause vasodilation. So we can affect our blood pressure with medications. This is what determines our blood pressure. All right, so what causes it, right? So most of the time when a patient comes to see you, they're gonna have what's called primary, also called essential hypertension, meaning that there's no specific cause, okay? There are causes, but there's nothing in particular there's not one cause. Genetics play a big role, and you'll learn this when you get to pharmacy and start talking about this. Certain people have a higher risk of having hypertension, or if you have a family history of hypertension, then you're at a greater risk of having hypertension. As we get older, those arteries start to stiffen, right? They just start to break down, not break down, but they start to become damaged, and when they become damaged, they start to have plaque, and so you get the stiffening of the arteries. If you are stressed, if you're a PA student, right, and you're stressed all the time, you're increasing that sympathetic system, then that's going to increase your blood pressure. If your diet's poor, you're eating lots of French fries and all kinds of sodium, well then, hey, that's going to increase that volume, and you're going to have a higher blood pressure. Secondary hypertension means that there's something specific causing this. There's something specific causing this, and that's why whenever you see your patient, you take that patient's history, and they have high blood pressure, you ask them like, hey, are you having any? Do you pee right? Do you pee normally? Are you peeing too much? What does your urine look like? Maybe they have some type of kidney issue. Are you not having blood in your urine? When you sleep at night, are you snoring? Are you waking up gasping for air? Has your spouse told you? Does your spouse have to sleep in another room because you snore so loudly? The sleep apnea can cause this, right? Different meds can cause this. If you're pregnant, that can increase the volume that you hold on to. So secondary, again, all it means is that there's something specific causing this. Okay. So what can we see with hypertension? Well, cardiomegaly is probably one of the biggest things that we worry about. We worry about other things, but if a person has hypertension and it's long-standing and it hasn't been treated, that heart has to pump against that high blood pressure, and when it does, that cardiac muscle is going to start to hypertrophy, right? That left ventricle is going to be the most common muscle that's going to first develop that hypertrophy because that's the guy doing all the force or all the pushing. Can the other parts of the heart start to hypertrophy? For sure, but that left ventricle, because what it has to do, what its job is pushing against that high blood pressure, that's going to be one of the first things that starts to grow and enlarge. Sometimes, if it's been prolonged, you can see this on a chest X-ray, and I'll show you a picture of that. But in order for us to make that diagnosis, it has to be greater than 50% of its chest width. And I'll show you what I mean. What causes cardiomegaly? So high blood pressure, obviously, chronically high blood pressure. If you just have it for a week, not going to happen. It has to be years and years. How many years? I don't know. Everybody's different, right? But it's a chronic type of problem. If you have a heart attack, that can cause it, right? So again, if we have a heart attack and we don't take out the whole, whatever part that's affected, we just take out a piece of it. So some of those cells die, but the rest live. Well, now those cells that are dead are no longer contributing to that pumping action anymore. So what's going to happen? The cells around that dead tissue are going to say, oh, this guy's not working. We need to get bigger. We need to get stronger to help this guy who's no longer working. So we can get these kind of sites where there's dead tissue, and then around that we have hypertrophy because it's trying to make up for the cells that have died. There's something called physiologic conditioning. So this is gonna be, you're gonna see this in your athletes, people who are very healthy, you know, for whatever reason, you get an echocardiogram on them for something unrelated, and the report comes back and it shows what they call symmetric enlargement. Essentially, all parts of the heart are gonna be enlarged. It's gonna be mild, but we don't care about that because what happens when you work out a muscle? It's gonna get bigger. This type of growth is not concerning. It's actually a good thing. It tells us that this person is healthy. Let's see. So when the heart does enlarge, when we have cardiomegaly, those cells are now bigger, right? And so now they require more oxygen to work. Bigger cell needs more oxygen. What can happen is that if you have these bigger cells and you have some type of atherosclerosis, and it's, you know, you don't have 100% of that blood flowing to those cells anymore. Maybe you have 50%. Maybe that's not enough for those now enlarged cells to actually do their job, right? And when you don't give that tissue enough oxygen, it starts to become ischemic. And when it starts to become ischemic for a very long time, it can actually die as well. So you worry about occlusion, that definitely is going to cause, you know, ischemia and quick death. But prolonged ischemia can also cause damage to the myocardium and cause cell death. So when those cells get bigger, they become ischemic because we're not giving it the kind of blood flow that it needs, and they can start to die. And what happens when cells die? We try to replace it with scar tissue, with fibrous tissue, right? When there's damage to a cell, our fibroblasts come in and they try to lay down scar tissue because we don't want that defect. We want something there to kind of patch it. The problem with scar tissue is that it's non-compliant, right? It's restricted. And so if you have scar tissue in the heart, it's not pumping like it should. It's not relaxing like it should. There's scar in there. And so when it tries to pump, it's not going to pump as well. When it tries to relax, it's not going to relax as well because now you have scar tissue in the heart. And so that makes that heart a lot stiffer and a poor contraction of blood flow. Now when you have this, right, when you start to affect the left side of the heart, if it's not contracting like it's supposed to, it's not pumping out blood, things start to back up, right? We start to get an increase in the blood in our pulmonary circulation. That's going to go to our right heart. And now our right heart's trying to pump out against this higher pressure in the pulmonary circulation. And now the right heart's going to start to hypertrophy. So you take out the left heart, or you cause issues with the left heart, inevitably you're going to have issues with the right side of the heart. All right, 10-minute break. Oh, real quick, cardiomegaly, do the chest x-ray. You can see how big that thing is. If you look over here, you got the normal heart and the enlarged heart. So not good. All right, take a break.
really wanna look at it.
I was like, I'm still breastfeeding. Yeah, that's why I took big bubbles. For calcium or? Go for what? Especially like your body can't absorb so a lot of it you're just federally takes up. I feel like just keep
So it's
So, it's slightly different because you have a piece of the it's basically the same thing. He showed us a picture where like it's the same thing, but the difference between dinosaurs is that the bone scans just
no. Oh, yeah. I mean, that's what I did. You don't. Yeah. Exactly. So, regardless of
Like, you know, like that.
you buy like the surge. We buy like I have it a lot. I got bamboozled by ACB. Really? I was like 5 minutes on the ground, like, I read like, I was like, the GoFundMe brand that HB has, the line of self getting that, she's like, oh no, you each of you want me to do the same. It's a GoFundMe brand, it's a standard off, like, I just got the if you look closely, it's a big product. This lady
Alright guys, I'm almost done with this lecture here, but I gotta move on to home. Alright, so, talk about cardiomegaly, congestive heart failure. So, we talked about this a little bit last block. So congestive heart failure, there's a lot of things that can cause congestive heart failure. When we talk about congestive heart failure though, we kind of try to break it up between left and right heart failure. Most of the time in real life, they're going to have some level of both. But just to make it easy, let's kind of go over the left side of failure first. So we call this forward failure because the left side of the heart pushes blood to the systemic circulation, right? So it's going forward. If there's something that damages that left ventricle, right? If there's somebody has a heart attack or they have hypertension that's causing that muscle to hypertrophy, anything that impacts the ability of that left ventricle to function normally, we get this backflow, right? Because it's not pushing out like it should anymore. It's not pushing that blood forward. It's starting to back up. And I've already kind of talked about it a lot already, but when it backs up, it goes to the right atrium. So that blood backs up, goes to the right atrium. And then that backup's going to go to our pulmonary circulation. Now when that happens, we can get pulmonary edema, right? If we increase that hydrostatic pressure, that vascular pressure in our pulmonary circulation, that pressure increase is going to push that fluid that's normally in our vessels out. It's going to push it out into that interstitial space first, and then it's going to push that fluid into the alveoli. And when that fluid gets into the alveoli, that's when we have issues, because now we have fluid there that shouldn't be there. And when that gas exchange is trying to take place, now you got this thing of fluid that's blocking it, so we're not getting that oxygenation like we should anymore. This is the problem with heart failure, is that blood is backing up, that fluid is getting into our alveoli, and now we can no longer oxygenate like we need to. Kind of talked about hypertension already, so you got that LVH, and you get that cardiomegaly or that growth of the heart. It can become stiff, not compliant, it's not going to contract, it's not going to relax like it's supposed to, so we get that back up. If you have a heart attack, you get the same thing. If you impair any piece of that left ventricle, and that tissue is dead, it's not going to contract like it's supposed to. Also, too, you're going to lay down scar tissue because that tissue is dead, it's not going to relax like it's supposed to. If you have some type of valve disease, so valve disease on the left side, typically it's that aortic stenosis, so the aortic valve, right, is stenotic. There's something that caused that valve to be stenotic. A lot of things can cause that, because think about your valves, right? They're opening and closing a lot throughout the day. On top of that, you're sending blood through that valve, especially on the left side, you're seeing a lot of blood through. It's going to cause damage. If there's damage that occurs throughout life, what's going to happen? You're going to get these calcifications there, dystrophic calcification. And that calcification can cause that valve to become stiff and narrow. So when we're trying to push blood through that aortic valve, got this small lumen, we've got this small, area that we're trying to push blood through. It's gonna increase that pressure on the left heart, which is gonna cause that heart to become hypertrophy eventually, and then send that blood back to the, or cause that blood to build up back to the pulmonary circulation. So that's left-sided heart failure. Right-sided heart failure. So right-sided heart failure is most often caused by left-sided heart failure. That should make sense. If we have a problem with the left, it's going to back up to our pulmonary circulation. When that happens, it's going to back up into our right side of our heart, right? Because if we have a high pressure in our pulmonary circulation, if we have pulmonary hypertension, right, then that right ventricle is trying to pump against this higher pressure in the pulmonary circulation, and as a result, that right ventricle is going to hypertrophy. And the same thing is going to happen. It's going to become stiff. It's going to become non-compliant. It's not going to contract like it's supposed to. It's not going to relax like it's supposed to. And when that happens, where does that back up to? Backs up into our venous side of the house. So we start getting edema, because now we have this hydrostatic pressure increasing in our venous side of the house. The liver starts to enlarge, because that liver, that blood from the liver goes to our inferior vena cava, to our right side of the heart. And if we have a buildup of fluid that's going to our liver, that liver is going to start to get a lot bigger. We can get ascites, we can get that fluid in our abdomen because things are backing up. JVD, you got to check in JVD, that's one of the things we care about here with heart failure, especially if it's right-sided. You lay it back, they're going to have that pressure in their jugular that you're going to be able to appreciate whenever you get that patient down. So left-sided heart failure is the most common reason why people get right-sided heart failure. If they just have a heart attack just to the right side of the heart, that can cause it too, right? Now there's one thing here, cor pulmonale. This is right-sided heart failure due to a lung disease. This is different than how we typically think about it. If we have some type of pulmonary issue, I'll talk about COPD in a couple of blocks here, a couple of lectures. But we talked about cystic fibrosis already, right? We talked about how that thing can cause these, our mucus to become thicker, right? And if it becomes thicker, it's going to block that lumen. So if we block that lumen where the airflow is trying to come through, we're not going to oxygenate as well. We're not going to get enough oxygen through. When our body starts to become hypoxic, especially our lungs, the pulmonary vessels start to constrict. They start to constrict. And so when they constrict, they increase that pulmonary pressure. It causes pulmonary hypertension. And when we have hypertension in our pulmonary system, that right ventricle is trying to pump against that pressure. And so that right side of the heart, the right ventricle, starts to fail essentially. And that's how you get right heart failure from a lung issue. So cor pulmonale is just from a lung issue. Okay? So these are some things you can see with left and right. So left side, kind of focusing on that blue here, makes sense. Impaired gas exchange, we have fluid, pulmonary edema. Again, we're pushing out that fluid that's in our pulmonary vessels into our alveoli. Cough with frothy sputum. So think about that. You have fluid in your lungs. You're also breathing in air, trying to at least. Whenever you cough that stuff up, that sputum is going to be mixed with air, so it's going to look frothy. It's going to have bubbles in it. Orthopnea, when the patient lays down, they're going to have trouble breathing. That's what orthopnea is. You have difficulty breathing when they're lying down. Most of the time when your patients have this, they're going to tell you, they're going to come and say, hey, I have to sleep in my recline chair because when I lay down, I can't breathe. Or I have to sleep with like 2 or 3 pillows under my back because when I lay down, I can't breathe. What's happening here is when you lay down, you no longer have that gravity kind of helping pull that blood back down to your extremities. So when you lay down, more blood flow is going into your heart. And your heart can't push that blood out because it's damaged, right? And so it builds up in that pulmonary vasculature, and so when you lay down, you get really short of breath. Paroxysmal nocturnal dyspnea, think of that as like a delayed orthopnea. What happens here is that typically a patient's going to lay down, they're not going to get short of breath right away, they're going to be sleeping, and then when you're asleep, right, your parasympathetic system comes into play. When your parasympathetic comes into play, your heart's not beating it's not beating normally, right? It's beating a lot slower. So because it's beating a lot slower and not as forcefully, it can't contract like it's supposed to or like normal. And so you get this difficulty pushing that blood out, so they have trouble breathing because you're not pushing blood out while you're asleep because of that parasympathetic tone. So it's kind of a delayed orthopnea. You still get short of breath when you're laying down, typically at night, but it just takes a little bit longer. Versus the right side, edema, we talked about that, liver congestion, so liver congestion equals hepatomegaly. You can get signs of impaired liver function, so sometimes you can get, if that liver's it's big, right, it's not gonna work like it's supposed to. You can get some spillage of your liver enzymes. Sometimes you have problems making your clotting factors, because that's where it's at. Sometimes you have problems making albumin, which makes the edema worse, right? So right side, think edema, left side, think trouble breathing. But in reality, most of the time they're gonna occur together. Here's a picture of kind of that JVD over here on the right-hand side. Got the ascites on the sky here in the middle, pulmonary edema with the chest x-ray, and then lower extremity edema down there with some edema. All right, questions about any of that? Cool. All right. Give me 1 sec, let me switch over here. Alright, so now focusing on the respiratory system, so there's 2 lectures with this, we're going to try to get through today, I don't know, I won't, but we'll see. Alright, so the respiratory system, quick overview, so the respiratory system is open, right, it's open to our environment, we have nothing kind of blocking, filtering what comes into our lungs, and as a result of that, we can get a lot of problems that happen there, we can inhale pathogens, bacteria, viruses, we can inhale carcinogens, pollutants, and all that can cause issues with our airway. The thing about the airway is that whatever affects our lungs typically affects our heart because they're so interconnected, and vice versa, really. So if you have lung pathology, you probably will have cardiac and vice versa. Quick recap, so when we break out the respiratory system, we try to break it out between upper and lower. With kids, we sometimes break it out to middle respiratory tract, and I'll explain what that means here in a second. And in our adults, we typically think about upper and lower. Upper, we have our sinuses, we have our nose that helps filter what's coming through. We have mucus in there that tries to trap whatever comes in there and we just blow it out. We have a larynx, that's where our vocal cords are at, right? But that's also the entry to our airway. So when something happens there, we have inflammation there or around there, we get really worried about somebody having some type of blockage there. The trachea, obviously that's where the air kind of first comes through, and then it branches out to the bronchi and the bronchioles. And we got the alveolar ducts and the alveoli, that's where that actual gas exchange takes place. On the right side, you have 3 lobes, and the left side, you have 2 lobes. And then outside of the lung, you have your pleura, right? And you have that pleural space. The pleura that attaches to the lung is called the visceral pleura, and then the one that attaches to the thoracic cavity is called the parietal pleura. And in between that pleura, you have fluid. Normally that fluid is supposed to be there, right? You want that fluid there as we inhale and exhale. There's a lot of friction going on. If we don't have that fluid, then it's going to start to cause issues. So talking about upper and middle respiratory tract. So I think this should say epiglottitis, not epiglottis, the first one. Just if you want to make that correction. I didn't catch that until this. So, okay, so URI, right? Everybody's had a URI. Everybody's had a cold before. Your patients are going to come in, they're going to have colds. The thing with colds is that there are a lot of things that can cause cold symptoms. The most common virus that causes the cold virus or cold symptoms is the rhinovirus. The problem with the rhinovirus is that there's not just one rhinovirus. There's other types of rhinovirus copies, right? So we can't make a vaccine against this. This is why we don't have a vaccine against the common cold. And on top of that, the common cold typically is very mild. People get sick, they feel like crap, and then after a few days they get better. With a URI, you're going to have those typical congestion, runny nose, cough, sore throat. The thing is that it's going to get better. It's going to get better typically within 7 to 10 days, maybe a little bit shorter, maybe a little bit longer, but we normally tell our patients, just give it 7 to 10 days, you should be getting better. Don't be fooled though, because your patient's going to come in and they're going to say, hey, I got a sinus infection. And you're, oh, why is that? Oh, because my mucus is green. Don't be fooled by that. The color of your congestion does not tell you if they have a sinus infection. They may have a sinus infection, it may be viral, okay, cool, it's not bacterial, right? Bacterial is typically, it stays for a lot longer, you typically have a fever, you have severe sinus pain. Cold, they're gonna come in with just feeling like crap, not really, maybe a fever, maybe not, most of the time not. But the color doesn't tell you anything, okay? Or what's causing that color is a few different things. When the neutrophils come and they try to, do their thing and try to kill off whatever's in there, they release this enzyme, and that enzyme looks green. The enzyme has a green tint, so when somebody comes in and they say, hey, my mucus is green, it doesn't mean anything. So don't get fooled by that when you see patients and they want antibiotics, because that's gonna be, that's a big thing. People come in, they want antibiotics because they know antibiotics work. Do they really work, or if you would have gave it time, that would have gotten better. And then we just treat these with rest and time. If they have prolonged symptoms, so greater than 14 days, you do run the risk of having initially a viral cold, but because our immune system couldn't fight it, and because we couldn't get those secretions out like we should have, because we have so much blockage in there, you do have bacteria in there as well. Normally that's in there. Sometimes when we have blockage and that bacteria can't escape, and sometimes you can get a secondary bacterial infection. Most of the time, the patient's going to present with double sickening, meaning they're sick, they're getting better, then they get sick again. That's the kind of a telltale sign of bacterial sinusitis. All right, so middle respiratory syndromes. So when we talk about these syndromes here, think kids, think children. Okay, these don't really happen in adults. The reason why we think children is because the way that the child's anatomy is. Think about the airway of a child. It's narrow. They're small, so it's a lot narrower. So when they have swelling and inflammation in there, what normally you and I, if we got sick with this, we feel like crap maybe, but we're not going to have, our airway is a lot wider, so we're not as symptomatic with this. Their airway's a lot shorter too, right? So our trachea comes up here, goes all the way down, and we have a lot of space. These guys are kind of compact, and so it's very easy for those infections to spread quickly to other parts of the body. When we talk about these middle respiratory syndromes, we're talking about epiglottitis, croup, and bronchiolitis. So epiglottitis. So all this means is that you have an inflamed and swollen, infected epiglottis, right? The epiglottis is that part that kind of comes down whenever you swallow that protects your airway. That way you don't aspirate food or fluids. So it comes down, covers that airway, and then when you're done swallowing, it comes back up, right? Most of the time, this is going to happen in our school-age children. So think 6 to 12 year old, right? 6 to 12 years old. They're going to school, right? They're sharing bugs with each other. It used to be Haemophilus influenza type B. Now, Haemophilus influenza type B is not a virus. I think you guys know that from micro. It sounds like a virus, but it's a bacteria. We vaccinate against this guy. We do a very good job of vaccinating our children against this, so we don't really see that in the States. Can you see it? Because people not vaccinated, for sure, you can still see it. But we've done such a good job on vaccinating that we don't typically see it in the States. The most common thing you may see is strep and staph, right? Strep and staph bacteria can get in there and cause this as well. But if you are out deployed somewhere and you're taking care of children, I mean, I went to Panama on a humanitarian assignment, and there were a lot of things that I saw there that I didn't see here, right? If you're out deployed somewhere, you still may run into this, and it may be Haemophilus influenza type B. With these guys, they're going to get sick quickly. Typically, it's going to be within a day or two. And they're going to have a high fever. They're going to have pain with swallowing. So when they swallow, it's going to be very painful. And as a result of that, they're not going to want to swallow. They're not going to want to swallow, so they're going to start drooling. Because every time they swallow, it hurts. So they rather not swallow, and their saliva is just going to kind of run their face and drool. You may also have this hot potato voice. So there's only 2 things that I know of that cause a hot potato voice. Maybe there's others, but these are the 2. This guy, and then a pharyngeal abscess, so an abscess in the back of the throat. We're not talking about that. We're talking about this, right? And when hot potato voice, it just sounds like kind of what it sounds like, right? You think about eating something hot and you try to talk, right? They're trying to talk, and because that epiglottis is inflamed, it doesn't just inflame the epiglottis, it inflames kind of the whole entire region. It can also inflame the vocal cords. It's going to sound like they're talking with something in their mouth. With these guys, they're going to have stridor. So all stridor is just a narrowing of the upper airway. So when they breathe in, there's going to be this high-pitched sound. It's going to be up here. That's what stridor is. It's a narrowing of the airway. and when that airflow's moving through, it's gonna be a high-pitched sound in the upper airway. So stride, think high, right? They're also gonna have this what's called tripod position. So this kid, he's having trouble breathing because you got this inflamed epiglottis, you got this narrowing of the airway. So what he's gonna do is he's gonna try to breathe. He's gonna try to make himself comfortable. And the way he's gonna do that is he's gonna sit up, he's gonna lean forward, he's gonna make his neck straight to try to open up that airway as much as he can. He will probably put his hands on his legs to kind of support himself. But that's classic. That's called a tripod position. So they're bent forward, neck is straight, and they're just trying to maintain that airway because there's so much inflammation and swelling that if they bend their neck or do something with their neck where it's flexed, it's going to make that a lot harder to breathe. You may see a thumbprint sign on a cervical spine X-ray. Typically, it's a lateral view where it kind of looks like there's a thumb poking out. That's that inflamed epiglottis. That's that swollen epiglottis that's just enlarged. For these guys, we're going to treat them with antibiotics. Don't really worry about the antibiotics for now. And if they get really bad, if they're really kind of declining and we're really, really concerned, then we're gonna put an endotracheal tube to try to make sure we maintain that airway. So here's that picture of the tripod position. So he's leaning forward, mouth open, his neck and chin is extended. He's leaning forward, hands on his knees there, trying to support his airway. That picture up top. So that normal, right, that's what normally this thing looks like in a child, very small. The mucosa is very pink, it looks healthy. Versus the inflamed one, look, that epiglottis is swollen. That thing is red, it's big. The surrounding tissue is also red and swollen. And that thing coming out of there, that's that endotracheal tube. This guy, they were really concerned that we're going to lose the airway, so they went ahead and did a trach on him, or endotracheal tube to support his airway. If that thing closes up, you can't breathe anymore, and that's bad sign. And then, I don't really like this normal picture, you can't really see well, but the thumbprint sign that you can see, it looks like a thumb, right? It looks like somebody's thumb is pointing out, so it's swollen epiglottis. All right, so moving on to croup. So you're definitely going to see croup. Croup is very common. It's called laryngeotracheal bronchitis. Easy way to just call it croup. This is mostly going to occur in our children who are 3 years old, so our preschoolers, right? I guess they're preschool all the time. 3 years old. This is most commonly due to the parainfluenza virus. Now, I have it here, right? You have edema of the larynx, the trachea, and the bronchi. But I have bold the larynx and trachea because that's what's most commonly affected here. The bronchi do get some inflammation, that's why you have that name, right? But the larynx and the trachea, that's where most of this issue kind of arises. The thing with this is that most of the time these kids get better with just time. It only lasts for about 3 to 5 days, and you'll see if you ever see a kid with this, they typically get better pretty quickly. But what's going to bring them into your clinic is that they're going to have this kind of weird, this kind of distinct cough. It's called a Barkley cough. It sounds like a seal cough. Has anybody ever heard croup before? Yeah. So if you haven't, maybe Google it, and you'll see it sounds very distinct. It doesn't sound like a normal cough. So parents are going to come in, they're going to say, hey, my kid has this weird cough. As soon as you hear that cough, you're going to say, oh, this is croup. You're going to check them, make sure they're good, make sure they're breathing normally, listen to the heart and lungs, look at their O2 sats. Most of the time, they're going to be fine. The thing with this croup is that it can worsen at night. So what happens at night? We sleep, right? Well, we lay some time for sure, but cortisol. We make cortisol. Cortisol is like our natural, anti-inflammatory that we make. At nighttime, our cortisol levels drop, and in the morning they peak. When our cortisol drops, we lose that anti-inflammatory benefit, which can make this worse because we have more inflammation. So at night, these kids are going to be a lot worse. Sometimes if you're working in the ER, urgent care, most time ER, they're gonna come to you at night with that kid 2 or 3 in the morning because, hey, my kid's coughed, he's been sick for a little while, he had like a cold, he was coughing, and then all of a sudden it's got really worse, and they'll come to you at night and you'll hear them cough, like, oh, okay, it's croup, not a big deal. What can happen here though, so we have the croup, we have the infection, and I told you that it can inflame that larynx and the trachea. So that subglottic space, so right before the vocal cords, right before the glottis is just to open the vocal cords. Right below that space, that's where that inflammation really starts to manifest, right? And that's what's causing this kind of weird distinct cough. And so when you do a X-ray on their neck, C-spine X-ray, it looks like a steeple. It kind of comes and then it kind of points at the very top where that inflammation is occurring, and it's a lot thinner. And I'll show you a picture of that here in a second. So what we're going to do, most of the time we're just going to treat these kids, we're going to just make sure that they're healthy, make sure they're not becoming severely hypoxic, which most of the time they're not. We can give them steroids. Typically, it's just a one-time dose of dexamethasone. Do you need it or not? I don't know. Maybe it's gonna make the parent feel better, and it's gonna make the kid feel better, so it doesn't hurt. It's just a one-time dose. If they're really bad, if they're really having trouble breathing, or if their O2 is starting to kind of decline a little bit, we can give them something called racemic epi. It's just it's a nebulizer, and I'll show you what a nebulizer here is in a second. But you inhale this medicine, and what that does is epinephrine is a vasoconstrictor, right? So that's going to cause our edema in that area to vasoconstrict as well. So we're not going to get as much edema. Those blood vessels are going to constrict. So that can help open up the airway pretty quickly. Now, if they're really, really bad, if they're dropping their O2, typically below, I guess don't worry about that. If it's getting low, or they're having really a hard time breathing, then we'll admit these guys, we'll intubate them just to make sure they're not getting too far off. But most of the time, it doesn't happen that way. Most of the time, they're just mildly sick. We'll give them dexamethasone, and they're good to go. So here's that picture of croup. So you can see that steeple sign, right? So you got this nice kind of open airway. Then where that inflammation edema is at kind of comes down to comes to a point. That's where the inflammation is occurring. That's a picture of a nebulizer. So it's just kind of pushing out this fine mist. And so we'll give that epi if we really need to. And then the trachea, if you see that cross section, you can see the normal, nice and open, and then when we have the inflammation, we get that narrowed inflammation. All right, so bronchiolitis. Bronchiolitis is one of those things that really affects our very young children. So our 2 and under, right? So 2 and under. Also, when we talk about kids, especially when they're that young, we use months too. So 24 months, right? So just remember that. So children too young, two and under. This is most of the time going to occur during that time when people get sick in the fall and the winter. You're getting colds. Well, this guy's coming through, and the thing that causes this is RSV, respiratory syncytial virus. This is what typically causes bronchiolitis in our children. What happens here is that they're going to inhale RSV, right? And it's going to affect the nasal mucosa first, and they're going to have just a cold. They're going to have congestion, runny nose, maybe a sore throat from that postnasal drip. They're going to have a cold. As that RSV virus starts to invade that nasal mucosa, it starts to kind of kill off that nasal mucosa because it starts to damage that mucosa. You're going to swallow that. And when you swallow that, you may aspirate that. You may aspirate some of that virus. It gets into our airway, and it's really the bronchioles, those very, very small airways. The bronchi are involved for sure, but those bronchioles are a lot smaller. So when those become infected and they start sloughing off their cells, what's going to happen? It's going to cause blockage of the bronchioles because they're so tiny. Because you have that blockage, these kids are going to have a hard time breathing. They're going to have a hard time breathing. They're going to have a short breath. They're going to try to cough up that obstruction because those cells are kind of occluding that bronchiole. And they're going to try to breathe faster because they're short of breath. They're going to be tachypnic. They're going to breathe faster. The thing with this is that there's wheezing with this, right? So I talked about stridor with the other one. Wheezing is associated with this because it's lower in the airway. These kids wheeze because I talked about like the thoracic pressure yesterday. When you inhale, right, you're opening up, you're decreasing the pressure. So when we do that, we kind of open things up, so to speak. So when you breathe in, you're not typically hearing wheezing. When you breathe out, you're making that pressure a lot smaller, right? So you're constricting those airways a lot more. So when we breathe out, that's when we typically hear the wheezing. It's a high pitch sound too, but it's a lot lower, okay? Now, most of the time, these kids are going to get better with just supportive care. There's nothing to really treat them with because it's a virus, right? We just want to make sure they're hydrating, they're breathing well. If they're really, really sick, if their O2 is less than 90, then we'll make the inpatient. And really, we're just supporting them, right? We're suctioning them. We'll give them oxygen if we need to, but most of the time, they're going to get better within a few days. All right, pneumonia. So pneumonia. All that means is that there's an infection, inflammation of lung tissue, right? Now, what do I mean by that? There's 2 types of pneumonia we care about. We have alveolar pneumonia, and we have interstitial pneumonia. Both of those have kind of separate causes. When we talk about the alveolar pneumonia, this is typically bacterial. Within that kind of overarching alveolar pneumonia, we can have different findings on our chest x-ray. We can have bronchopneumonia, we can have lobar pneumonia, but they're still alveolar pneumonia. They're that because the alveoli are affected. With the bronchopneumonia, you get these focal patches, consolidation of infection. So it's not the entire lung that's infected, it's just these patches of these alveoli that are infected. When they're infected, they start to become permeable, and we start to get that infiltration. Remember talking about infiltration? There's another term that's related to infiltration called consolidation. It's just a more specific term for a pneumonia, where you just have fluid in the alveoli. So you get consolidation. So you may get in real life, you may get a chest X-ray report that says, patchy infiltration in whatever lobe, or you may see consolidation in this lobe. Kind of means the same thing. Infiltration is more generic, consolidation is more specific for pneumonia. With lobar pneumonia, this is a diffuse infection, so it's contiguous, it's hitting all the alveoli in that lobe, okay? It's typically one lobe, typically. Can it be more? For sure it can, but most of the time, that lobe is going to be infected, and when they come in, you can treat that pretty quickly. With the chest X-ray, it's going to be uniform consolidation. I'll show you a picture here in a sec. Now, with interstitial pneumonia, this is different, right? The alveoli are not infected. There's no fluid in the alveoli. The fluid, the inflammation, is outside the alveoli. It's in the interstitial space, okay? What causes this are typically viruses, so really any type of respiratory virus, or atypical bacteria. When we talk about atypical, we're talking about mycoplasma pneumoniae. The reason why it's atypical is because it doesn't have a bacterial cell wall, so that's why we call it atypical, but it's still a bacteria. So we have viruses, we have atypical bacteria, not the typical bacteria. With this one, it's typically going to affect both lungs. It's going to be bilateral. You're going to get this kind of diffuse, so it's going to be spread out, what's called reticular pattern. So reticular, all that means is that it kind of looks lacy. I'll show you a picture here in a sec. So imagine you have a chest X-ray that's normal. You just have a fine lace on it. It's going to look kind of like spider web in a sense, right? But you're not going to have consolidation with this. You're not going to have fluid in the alveoli. That fluid is outside the alveoli. Now, there's two, when we talk about pneumonia, we really also care about, did this happen in the community? Did it happen really outside of the hospital, or did it happen within the hospital? Because if it happened outside of the hospital, we're still concerned. We've got to treat this because pneumonia is deadly. But I'm not as concerned as if you were in the hospital and got this, because what's in the hospital? A bunch of sick people have a bunch of weird diseases and a bunch of bacteria that we don't normally see in the outside. So if you have community-acquired pneumonia, it makes me feel better because I can treat this probably easily. If you develop this pneumonia in the hospital, it's typically within 48 hours of admission, or after 48 hours of admission, that's when we get worried that this is a hospital-acquired pneumonia. So here's that bronchopneumonia. So this one's bilateral, right? It's shown bilateral. Can it be unilateral? Yes. Don't let the bilateral fact, or the picture, the fact that this is bilateral, dissuade you from interstitial if you ever see that. But bronchopneumonia, you got these patches of consolidation versus lobar pneumonia. You look at that right upper lobe, that thing is homogeneous, right? It's full of fluid. You can see where it starts and stops. So that's that lobar pneumonia. And then interstitial, again, this is that kind of spiderweb-like appearance. It's hard to kind of tell, is this pulmonary edema or not? The more you look at chest X-rays, the easier it is. And then also you take into account, like, is this guy young or old? Is he having trouble breathing? Is he coughing up any sputum? Right? You got to take that history too into account. This is what interstitial looks like. And that picture there kind of shows you if you put some type of lace over that chest X-ray, you'll get that kind of appearance. So pneumonias. Okay, so there's different causes of pneumonia, different types of pathogen bacteria. These are focusing on bacteria. Strep pneumonia, most common cause of community-acquired pneumonia. We have vaccines for this. Typically we give this to our older folks, and most of the time we'll actually give it to our people who have lung disease as well. But most common cause, influenza type B, again that's that bacteria that also causes epiglottitis. We have a vaccine for this too. Klebsiella pneumoniae. Klebsiella, so Mr. Weber, who used to teach this class, used to say, Kleb likes his cocktails. So if that helps you remember that, these are going to be associated with our alcoholics, people who drink alcohol. This Klebsiella is normally found in our GI tract, right? It's good, it's fine, it should be there. If we have some type of aspiration of this pathogen that belongs in our GI tract, if we're alcoholic, we're throwing up, breathe that stuff in, that's when it gets into our lung tissue, and that's when it causes the destruction that it can. So very, very bad, but typically associated with alcoholics. Sometimes with these guys, because it's so pathogenic, you can get what's called a red currant jelly sputum. So essentially it's kind of this mucousy, bloody looking sputum. A currant is just kind of a berry, right? And then you imagine kind of mixing that up and making jelly with it. But it's a thick red sputum that comes up from bleeding because this pathogen is so deadly or so bad for lungs. Staph aureus, this is the most common cause of hospital-acquired pneumonia. You think hospital has a bunch of sick people, they're using all, they're cleaning their stuff, they're cleaning their rooms, but can stuff still kind of go from one patient to another? Absolutely. The thing with Staph aureus is that this is most commonly associated with an abscess in the lung. So I told you guys last block that we can get abscesses, right? And I told you that Staph is one of those that's very virulent. This guy can cause an abscess in the lung as well. And then Pseudomonas, this is another typically hospital-acquired pneumonia. Most of the time you're going to see these in very, very sick people, especially people who have lung disease, especially cystic fibrosis, because they can't get those secretions out. So if you're in the hospital and there's Pseudomonas running around, and it gets into the lung, especially in a sick person who has a bad lung disease, and that can definitely lead to sepsis, potentially, and death. But again, there's kind of some key words there, right? And if, so key words there. All right, so moving on to so viral atypical pneumonia, right? I talked about that interstitial pneumonia. Viruses can definitely cause that. Pick your respiratory virus, that can cause this. And then the mycoplasma pneumoniae. Now the thing with the mycoplasma pneumoniae is that this is what we call walking pneumonia. So you've ever heard the term walking pneumonia? The reason why it's called walking pneumonia is because these people have pneumonia, but they look fine, they look healthy. The main thing that's going to bring these people in is that they've been having this, they got sick, and they've had this cough for a month, 2 months, 3 months, right? They overall feel fine, but they just keep coughing and coughing and coughing. You really need to worry about this in your young people, especially those who live around or who are living close together. Guess what? You're going to be seeing people who just came out of boot camp, who came out of training, they were living in the dorms together, they were living in the barracks together. And so this is one of those things that we get really, really worried about whenever people are living close together. And in fact, I don't know if it's happened with you guys, but when I went to boot camp, they gave me some antibiotics. I forgot. It was to prevent this because it was so rampant that when you live close together, especially in the barracks, you worry about people getting this mycoplasma pneumonia, this walking pneumonia. Like I said, they may initially kind of have these kind of mild symptoms, cough. Most of the time it's non-productive though. It's non-productive because the alveoli are not the problem here. It's outside the alveoli. So they're not making this fluid inside the alveoli. So they're just coughing, but there's nothing coming up. And again, the key thing is that it's prolonged. A month, 2 months, 3 months, they finally get sick of it and they come and see you. You shoot a chest x-ray, you see this interstitial pattern. Okay, great. With a virus, normally they're going to come see you, they're going to get better pretty quickly. With the atypical agents, the mycoplasma pneumoniae, they're not going to get better quickly. They're going to come see you after a month or two, and that's when we treat them with antibiotics. Most of the time we'll give them a Z-Pak, azithromycin, 5 days, they're better, right? Sometimes a little bit longer, but typically 5 days. So this is just a little table for you guys. This is kind of compare and contrast. Hopefully it's helpful, but if you really know those slides there that I just talked about, it can be good. All right, so fungal pneumonia. So most of the time, when we inhale, fungi, right? They're found everywhere. They're found in the soil, they're found in droppings of birds and bats, they're everywhere. There are certain regions in the United States that are associated with specific pneumonia, specific fungal pneumonia. Histoplasmosis is typically found in the Midwestern, so that Mississippi, Ohio River Valley is called river fever because of where it's at. You're going to find these typically in bird and bat droppings. People who go in caves or who go in old buildings and these spores are floating around, they inhale these, you can get this type of pneumonia. When you're healthy though, our body does a very good job of kind of encapsulating it. It's not going to cause too many symptoms. If you get older or your immune system starts to decline, then sometimes this can cause issues. But most of the time, the way we actually find this is that somebody comes in for whatever issue, we shoot a chest x-ray, and they have these nodules, granulomas. They have multiple of them. And so we're like, hey, where have you lived? And we have lived everywhere, right? Which make it hard. But if they tell you, hey, I was living in the Mississippi, Ohio Ohio River Valley region, okay, maybe it's that, right? Versus coccidiomycosis, this is more found in the southwestern part of the states, and it's typically found in the desert soil, dust. But these two are very specific for the region. So definitely parents like psoriasis for some reason, but that's one of those things we know. So when we have this, the patient may have no symptoms, or they may have very kind of vague, mild symptoms that get better. But we shoot that chest X-ray and we see these granulomas, these nodules in the lungs. And all that is that we inhaled the spore, our immune system came, our white blood cells came, and they try to encapsulate. Very similar to TB. Very similar to TB. The thing with TB is that TB is a bacteria. This is a fungus, but it treats it kind of the same. We don't really treat, so if somebody has a granuloma and they're asymptomatic and we rule out TB, right? I'll talk about that here in a second. We don't do anything for this. We don't treat it with any type of antifungals. You'll learn antifungals are dangerous. They cause a lot of liver issues, especially when they're taken for a long time. So we don't treat this. If they're symptomatic, well then we'll treat it, but there's a lot that comes with that. So here are those regions. That red there is that coccidiomycosis, and then it's kind of darker green is the histoplasmosis, or lighter green. But kind of look where it emerges, right? We're kind of in that area where we can go either way. So those regions are very specific for those types of pathogens. Here's what that can look like on chest X-ray. So this got this coin lesion. I know this was talked about in micro for sure. So that's just that nodule, that's that granuloma that's covered up, that's covering that pathogen. And then over here you got these smaller nodules that are kind of advancing. This guy actually looks, the one on the right, looks pretty nasty, but typically it's like one, maybe two nodules. It doesn't typically look like it's disseminated. All right, TB. So TB, you guys talk about TB in micro, I would think, but TB is one of those things that people have this, right? It's not very common in the States, but outside the United States, it's very, very common. We call it an acid-fast bacillus because it has this waxy capsule. I'll talk about that capsule here in a second. But when they stain this guy, and then they try to, when you stain some type of pathogen, there's different ways of doing it, but we try to, we stain it with one color, and then we throw this acid wash on it, and it should take that color off, and then we stain it again with another color. With this guy, when we stain it and try to wash that acid off, it doesn't wash off. Or when we throw acid on it, it's an alcohol acid. We try to wash it off, it doesn't wash off, so it stays red. That's why it's called acid fast. That's all it is. But that waxy wall, that's the problem here. That's what protects the TB from actually getting killed by our body. Because our macrophages come in, they eat it, they try to destroy it with their enzymes, but they can't because of this waxy wall. That waxy wall protects it. So what do, right? If we can't kill it, we're going to put it in gel. We're going to try to put it in gel, that way it doesn't spread to our body. Now the macrophage, it ate the TB. TB's inside of this guy. It's trying to kill it, but it can't. So our cytotoxic cells, our CD8 cells, are going to come through, and they're going to say, hey, you're infected with this thing, you can't kill it, I'm going to kill you instead. So our CD8 cells come and they kill the macrophage. But the problem is that TB is still there. You just killed the macrophage to try to kill it. So now what, right? So now we have this live TB still there. And so our immune system is going to come in and they're going to make these granulomas. And I talked about that. Those macrophages, talk about it with the temporal arteritis, right? The macrophages come in, they can fuse together, and they make these giant cells. These giant cells will make up this granuloma. So it's like you got the TB that's still there, you got a bunch of red white cells, and then surrounding this, you have those macrophages, other macrophages that are combining, putting this TB in gel so it doesn't escape, right? So that's what actually makes up that caseous necrosis. We talked about that last block where we got this cheesy type of necrosis. All that caseous necrosis is just these dead white cells, this live TB, some of the tissue that got destroyed in the process. And so that's what makes up that caseous necrosis. So how is it going to present? So we can have primary disease in the late phase, and then we can have reactivation. So primary disease in the late phase means we encountered TB, right? We got TB, our immune system made these granulomas, and when you shoot that chest X-ray, you're going to see what's called a Gond complex. All that is a granuloma, and if you look at the hilar region of the chest X-ray, you have lymph nodes there. because our immune system is activated trying to combat this TB, those lymph nodes are going to get swollen. So you get lymphadenopathy in that hilar region, that region where the pulmonary artery, pulmonary vein, the bronchioles kind of insert into the lung. That center region, that's that hilar region that you get lymphadenopathy there. We put the TB in gel. Okay, now it's in gel. It's not spreading. It's dormant, so to speak. Okay, fine, good. It's there. You still have TB, but it's not contagious because we're now trapping it in this place. Then years go on. You get older. Your immune system starts to fail. You get HIV. You take a medication that lowers your immune system. Whatever. You lower that immune system, and now that granuloma can no longer keep that TB confined. What happens is that TB says, "Hey, you're weak now. I'm gonna break out of jail, and I'm gonna go to the top of the lung, the apex." TB needs oxygen to survive. It needs oxygen. You're gonna have the most oxygen tension, the most oxygen in your apex of your lung. So it loves to go to the apex of your lungs. So with reactivation, you can get apical pneumonia. So pneumonia at the very top of your lungs. Without oxygen, it can't survive. So it's gonna go to a place where it's gonna have the best chance of survival. When that TB's there, it's going to do its thing. It's gonna start to replicate. It's gonna start to destroy tissue. It may go into your bronchi, cough it out, spread it to somebody else, and actually bring it to a blood vessel and go to other parts of the body. So TB definitely affects the lung, but it can go to the brain, it can go to the liver. It's kind of like cancer, it can metastasize to other parts of the body. So features of TB. So typically, most of the time actually, people don't have any symptoms. Because our body does such, especially when you're young, our body does such a good job of putting this thing in gel that you may not know you have it. So you may not have no symptoms. If that happens, right? If that happens, so we screen for TB in the military. Most of the time when we catch this is when we do that PPD test, that hypersensitivity 4 test, right? When we do the PPD, if this thing comes back, if the patient comes back 2 days later and they have induration where we inserted that antigen, that makes us say, oh, this person may have TB. The problem with this test, though, the problem with PPD is that you have a lot of people who were born in other countries, and other countries have a vaccine against TB. So if somebody had a vaccine against TB, and then you do that PPD test, it's going to be positive. It's going to be positive, right? So typically, we're going to ask that patient before in real life. We're going to say, hey, have you had the vaccine against TB wherever you were born? They're going to say, yeah. So the other thing we can do is do this interferon gamma release assay. You may have heard quantiferon TB Gold. It's a blood test you can do. So when somebody's had a TB vaccine, we can actually check for TB with the blood test as well. But either way, if one of them are positive and they haven't had the vaccine before, we shoot a chest X-ray. We see these granulomas with that lymphadenopathy, that GON complex, right? And they're asymptomatic, they're not coughing, they're not having fevers, they're fine, then we diagnose them with latent TB. They're not infectious, they're not gonna transmit anything because, yes, they have TB, but it's in gel, right? We'll normally treat that, we'll normally treat them with a combination of medications for a set number of time, but it's non-contagious, so you don't have to worry about them spreading this to other people. If somebody has active TB, if you do that test, PPD or the IGRA, and they're symptomatic, they're coughing, you see that apical pneumonia, ideally we want to try to get a sputum sample from that patient just to verify that that's what's going on here. The problem is that when you try to grow out this bacteria, it takes a very long time. We're still going to treat it, but if we can, we're going to get a sputum sample. But we're definitely going to treat this with a host of antibiotics. But the thing with that is once it's reactivated, they are infectious. So late TB, not infectious. Reactivation, definitely infectious. We're almost done here. Let me just kind of get through these few slides. So here's that picture of the GON complex. So you see over here, you got this nodule right here, and then you see over here, you get that hyaluronadenopathy, and that picture in the middle is what this is supposed to look like. And on the right-hand side, you got that apical pneumonia, so you got this kind of consolidation at the very top of the apex. That's that reactivation. All right. Can we get through this? That's okay. We'll finish tomorrow. Thank you. Any questions? stuff.